Very good. Okay. How's the water? Okay. Ladies and gentlemen, very welcome to you all, and a very special warm welcome to our distinguished panel, Ministers of Health, High Representatives of countries, and KNCV Tuberculosis Foundation. This is an important panel. I will introduce you when I give you the floor. But I'm really very pleased that you are willing to discuss this specific item, important in progress towards our goals. Monitoring and evaluation is a critical component. And if we jointly want to bring down tuberculosis, we have to know what we are doing. First and foremost, it is of importance to reliably measure the size of the problem and whether we are indeed on track to achieve the targets as formulated in the Sustainable Development Goals and WHO's End TB strategy. Let us remind ourselves that our goal is to end the epidemic by 2030, a tall order. As the Minister of Health of South Africa and chair of the Stop TB Partnership said so eloquently yesterday, we need good data to monitor progress. Secondly, I think it's of importance to be accountable to the world about the impact that we are making on the epidemic, including the numbers of lives saved, deaths averted. Let us be deeply aware of the fact that we have collectively saved more than an estimated 50 million lives, since the year 2000. And if a robust vital registration system would have been in place everywhere, that would not have been an estimate, but that would have been a fact. Thus, our distinguished panel focuses on the importance of the transition to a national electronic case-based TB surveillance system and to the development of a national vital registration system with coding of cause of death, and of course, the urgency of effectively engaging the private sector as too many cases go unreported. In the interest of a lively discussion, we have also an opportunity to explore other aspects of TB surveillance. Kindly note, we have only 90 minutes. We know that problem from yesterday, I think. We had a lunch at 3:30. We don't want that today. In which 9 distinguished representatives of countries should have each a fair chance to give their perspective. So we have allotted you each 5 minutes, so everybody can have a fair share. At the end, I hope we will have some time for discussion among each other and with the audience. We will see how far we come. I will be a little bit firm as moderator to say, please summarize, so everybody can get his voice. There will be an extra challenge for Korea, because there will be direct translation, but I'm sure together we will manage to do that. So let's start our deliberations. And we will start with Myanmar, one of the highest TB burden countries in Southeast Asia. Myanmar is a recognized leader in prevalence survey methodology, and globally the first country to carry out a survey of costs faced by TB patients and their households. And my question to His Excellency, the Honorable Minister of Health, Dr. Myint Htwe, is: what is your perspective and view on monitoring and evaluation of the TB program in terms of achieving the Sustainable Development Goals and TB targets, as well as the other SDG goals? The floor is yours.
Thank you, sir. Good morning, my colleague ministers, as well as distinguished guests, ladies and gentlemen. I would like to share my views on the given topic from the data, information, and epidemiological perspective in order to achieve SDG target 3.3. In that context, we need to emphasize more on how to detect hidden cases or undetected cases as we go along. When we say that, we have to ask one question: are we progressing very well towards SDG 3.3 in order to have an impact on TB epidemic? While we are contemplating this, we need to sincerely ask, is our trend or progress of our work acceptable at this point in time? We should not take it for granted. We have to think that way. What are the areas that we further need to boost it, given the fact that the data that we have at this point in time? This meeting, I'm sure, will give many of the answers all along the way. When we go home, ministers ourselves, we have to meet with the TB program professionals at different hierarchical level of the health system, and also community-based organizations and like-minded organizations as to how we should further progress or how we should speed up the progress that we have at this point in time. The key issue is that when we say we are on track, we are on track, how far are we sure? How far are we confident that we are on track? We should not be satisfied on the data that we have in the reports and return. The data by itself speaks, but to what extent this data truly reflects the ground reality of TB scenario in our country? That is very important. We said, stop TB. I would even like to say, stop analyzing data for a while only, until certain aspects in the data, reports, and returns are clarified. Why? We have to ask why again. By saying this, I'm not pessimistic. In fact, I'm optimistic. All of us know that in disease epidemiology, when we look at the data, we have to see from negative perspective. But when we give inference and comments, we have to see from positive perspective. That is very important. In the developing, I'm talking in the context of the developing country scenario, we need to do a little bit of introspection as to the data of TB that we have in our hand regarding its validity, reliability, comprehensiveness, real-time or not? Are there any data gaps in different perspectives? And what about the trend pattern? Is it on the increasing trend or decreasing trend on several parameters that we are going to assess TB control? And also, what about the mapping of TB cases in various states and regions in different parts of the country? Because the reason being that these are the parameters which can serve as a key determinants in advancing the so-called TB response effectively. All TB programs, as you know, are striving hard to detect more hidden cases and to have more undetected cases being identified. Here, quantitative data, as we all know, is very important from epidemiological perspective of TB control program. But what is more important in order to detect hidden cases or undetected cases, qualitative perspective of data is very, very important. For instance, if we detect one hidden case of TB or one undetected case of TB, we have to ask qualitatively why this case was not detected, why this hidden case was not detected in 2 months, 3 months, or even 6 months' time. Why? The reasons. We have to find out the reasons by doing quantitative questions. It may be because of the fact that weakness in TB control program in a particular part or particular region of the country, not necessarily the whole country. And the patients are not knowing that they are suffering from TB due to the fact that the health literacy of the population in that particular region is not up to the mark or somewhat low. And socioeconomic perspective of the patients. And also patients do not possess the ability to make decisions to go to the health clinic. Probably their grandmother, grandfather deter them not to go to the health clinics. All these factors and many others can be exposed a bit if we do some sort of an operational research or implementation research while we are improving the data at hand. We can then effectively strategizing or even re-strategizing TB control program by improving case-finding activities accordingly. Only then we will be able to achieve the set SDG targets by 2030. In other words, we should not do business as usual approach in detecting hidden case of TB. We need to do out-of-the-box thinking, innovative thinkings to detect more hidden cases. That is important. Why? The causes of not detecting hidden cases may be different from region to region, place to place, even in one country. So we have to target those reasons to improve it so that we can be able to detect more hidden cases or undetected TB cases. We cannot, what I would like to say, we cannot use the blanket approach for the whole country, and the blanket approach must be tailored or fine-tuned to suit the local context. Local context means region-specific context, township-specific context, provisional-specific context. This point needs to be seriously considered for effectively strategizing, even using different strategic approach. I should say, even using different strategic approach than the strategies that we are currently using. My final word is that monitoring and evaluation of TB control program is only meaningful if we do a little bit of introspection on the data that we have at this point in time and re-strategizing to make it much more efficient. Last but not the least, we have to increase the health literacy level of the population on TB so that we can be able to detect more hidden cases. That is very important. So monitoring and evaluation of progress is only meaningful if all the hidden cases are included in our database. Thank you very much, sir.
Thank you very much, Honorable Minister, for pointing out the importance of context-specific actions of the program and also alluding to the fact that patients may have delay in accessing the health service and the health service has to be improved if that delay is unacceptable. But also your more philosophical remark on look at the positive side of data, what can we learn from that and strengthen, and not only look at the negative side of data. Thank you very, very much appreciated. We may now move to, let me see, we move now to Zambia. Sorry, the name of your country was missing from my perspective, what is a terrible thing. As a country, Zambia faces a very high TB-HIV burden, but developed a robust TB-HIV surveillance system and recently conducted a prevalence survey. My question to Your Excellency, the Honorable Minister of Health, Dr. Chitalu Chilufya, is kindly share with us how Zambia will manage the transition to an electronic TB case-based surveillance system and develop a viable national vital registration system with coding of cause of death. The floor is yours, sir.
Thank you very much, Moderator, and colleague panelists, and the distinguished delegates for this opportunity to talk to this subject of electronic TB case surveillance system in relation to monitoring and evaluation. Now, monitoring and evaluation is a fundamental component of a successful NTB strategy, and it is therefore very important that we invest in very strong M&E programs. Now, in Zambia, we have embraced information and communication technology to strengthen governance and health service delivery. And as part of our e-governance program, we've introduced e-health to strengthen health systems, in particular the fundamental variable of health information management systems. Refocusing now on tuberculosis. Yes, as you rightly said, Zambia conducted a TB prevalence survey, and we discovered that the TB prevalence incidence in Zambia is at 391 per 100,000, which represented a 40% reduction from 650 per 100,000 10 years ago. Now, until the end of 2015, TB surveillance was done through a paper-based system, and this used to be conducted through data flowing from health facility to district to the province and then to the national level. But in 2016, Zambia migrated to the DHIS2 platform, allowing the real-time flow of information at all levels. In just under 15 months, 100% TB data reporting through a web-based DHIS2 system has been achieved. Now, with the support of the United States government through USAID-funded projects, we are now constructing a TB case-based electronic module, which will be embedded through the existing DHIS2. Now, this electronic case-based module will be incorporating both drug-susceptible and drug-resistant TB and leprosy data. And moving away to the next aspect of the question, civil registration and vital statistics. Well, to improve civil registration and vital statistics system in Zambia, the country is now implementing the Civil Registration and Vital Statistics Strategic Plan 2017 to 2021, in which we intend to increase, amongst other variables, death registration. Now, to capture deaths, information for deaths which are non-facility based and generate tentative causes of death, deaths that are not seen by a physician, we're now doing physician sample vital registration with verbal autopsy, which is carried out periodically. I want to conclude by emphasizing that in our quest to strengthen health systems towards universal health coverage, towards universal TB care and prevention, it is important that we appropriate sufficient and sustainable financing for TB programming, including M&E programs. And this is the only way we're going to monitor our progress towards our progress in our march towards ending TB by the year 2030. I thank you.
Thank you very much, Honorable Minister. And it is really very encouraging to hear your movement in e-health, to which TB will benefit enormously, the notification system, and your move towards a national vital registration system and strengthen it further. I think that is an excellent way forward. Thank you very much for sharing this information with us. I propose we move to Uganda. Uganda is also seriously addressing its imposing TB HIV co-infection problem, and carried out a high-quality national TB prevalence survey recently. Due to unfortunate circumstances, Dr. Aceng Ruth, the Minister of Health, could not attend, but we are very pleased that William Ndolereire, Assistant Commissioner at the Ministry of Finance, Planning and Economic Development, perhaps even more important for TB nowadays, is willing to address our question. My question to you, Honorable Commissioner, is how has surveillance information gathered on the status of TB-HIV co-infection in Uganda influenced national TB policies and day-to-day programmatic operations?
Okay, thank you, Moderator, the panel members, and the delegates, ladies and gentlemen. First, you clearly put I am standing in for the Honorable Minister, who was unable to come, and therefore I'm making this submission on her behalf. So when you see me changing to a lady's voice, you know that I'm emphasizing her point. Quickly to come to the point is on the background, 1983, that's when the HIV issue came up in Uganda and was officially mentioned in 1986. That means that before 2004, when the WHO guideline came in for the TB-HIV collaboration, the government of Uganda was not doing much on that, as the TB program came into force in 1988. So in 2006, government of Uganda adopted the World Health Organization TB-HIV collaboration guidelines, and the approach we took was to set the National Coordination Committee for HIV-TB was formed. We did the adoption of the policy. We did the training of service providers, and also did the change or the revising of the recording and the reporting tools so that we have a link of the HIV and the TB co-infection. And what is important to note is that there was an overlapping in the process whereby the implementation and the surveillance was done at the same time, being translated in a quarterly basis. Now, how it was adopted, we took two windows. There was a window focusing on the TB, whereby all the TB patients were screened for HIV. CPT was given to all patients with TB, HIV co-infected, and also ARVs was also given to all TB, HIV co-infected patients with a special focus on treatment for TBs as we monitored the co-infection rate. Under the second window, we looked at the HIV. On the HIV, we intensified TB case findings among the HIV positive, looked at the implementation on IPT preventive treatment for all that have HIV but not TB, and the infection control measures, which is important to ensure there is preventive. And lastly, the part which came in later was the integration of the TB, HIV services. Now, in doing this, we are using a number of monitoring indicators, and some of which is on the HIV testing vis-a-vis or amongst all of those presumed or co-infected, those who are confirmed to have TB patients, and also looked at the proportion of the TB patients with HIV positive status, and looking at all of those who are at risk, TB at risk, especially those who are TB screened negative, those which are HIV positive at all ages, those in prison, such that all those cases are put into perspective. The results, before I can come in to the part of the implication on the policy and the day-to-day operation. It was noted that there were different health workers compared to the service provision. So we are focusing on the integration of HIV, TB co-infection, but the health workers' mind was not integrated. The second was that the process were also not synchronized. There were different clinics on different days. Monday, a TB clinic. Tuesday, HIV clinic. So that part was also not synchronized, and it affected. Then the TB patients were not on the CPT. Then the screening was not done for all the TB patients. And what was also to note is that came out was the HIV-TB co-infection rate reduced from the earlier 60% to the current level of 41% of the TB diagnosed patients. Now, as I come to the main gist, how has this surveillance helped on the policy direction? Now, following what has come in on that, we realized that the focus on the TB and the focus on the HIV is not put together. So it became important that we move from collaboration of the two to go into the integration, such that we focus on the training of the nurses, such that the nurses' mind, the focus is also integrated. When you look at the TB patient, you bring in the HIV element. The treatment mode on the clinics became one clinic, such that the clinic for TB and the clinic for HIV is handled at a go, such that there is that integration. Then the third part was to go beyond looking at a patient, but focus on all aspects that relate. Whoever is suspected is treated, is handled, other than looking at a patient who has to be treated. And the second effect on or how it has been influenced under the policy is in the 2016 Moderator, as you had indicated, we are in the process of finalizing the undertaking to further integrate and expand to a one-stop shop for all the TB and HIV, bring in the maternal productive health, bring in the adolescent and children. In that form, we have to make sure there is access of HIV and TB in an integrated service. We see moving forward here that when we do that integrated approach, we may have to move the 90-90-90 for HIV to pushing it to a 90-90-90 for TB, because it is integrated. Whoever is looked at HIV is the same mode that is applied for TB. So that means the approach for the 90-90-90 for HIV can also push to a 90-90-90 for TB. And again, lastly, we are also in the process of undertaking an evaluation of the impact of HIV, TB collaboration, focusing on the data that would be picked from the period 2006 to 2015. And that one will give us further information to deepen the policy direction on HIV, TB. In conclusion, the major part of the challenge has been more to put on digital X-rays to give that support. That is the next focus. The other one is to have more on the gene expert machines, which is programmed to increase from the current level of 131 to 200 by the end of 2018, and then to close to 400 to cover all of the TB surveillance centers. And lastly on that is to focus on the community health system support, as it was indicated yesterday, especially when I picked the word from the representative of the regional office for Europe, who emphasized the issue of the socio-economic determinants as the key component to end the TB, and what was also emphasized by the civil society, especially the representative from Masai, who indicated the role of the family, how it helped her to take the medication. Putting all together, that's how Uganda intends to move forward on that, such that if we have no action today, then no cure tomorrow. I thank you.
Thank you very much, Honorable Commissioner, for your clear illustration of the fact that good surveillance can be followed by programmatic improvement, not only in tuberculosis, but in the collaboration of two programs. I think that is a very, very good example. Thank you very much for that. May we now move to Mongolia. Mongolia has successfully carried out also a national TB prevalence survey, and in that survey also identified TB high-risk groups, such as prisoners and homeless. My question to Her Excellency, the Honorable Minister of Health, Dr. Mrs. Sarangerel, is the following. Kindly illustrate the specific challenges faced by Mongolia in strengthening TB surveillance among certain risk groups, as there are prisoners and homeless, and how you will address them. The floor is yours, Madam.
Good morning, everybody who gathered here. Mongolia is a small country, which is located between big country, Russia and China. The population of Mongolia is about 3 million. And what is the main challenges, TB challenges in Mongolia? To save the time, I will quickly read my information about TB condition in Mongolia. So, TB remains a major public health concern in Mongolia. Recent drug resistance survey showed increase of multi-drug resistant TB prevalence from 1.4 in 2007 to 5.3% in 2017 among new cases of TB. The Ministry of Health of Mongolia is committed to leaving no one behind, therefore addressing TB in high-risk groups of population such as household contacts of smear-positive TB cases, prison inmates, homeless people, minors, and elderly is priority. There are around 3,000 people are reported being homeless in the country, and TB rates are 5.4 times higher among these people than general population. People who are homeless often lack access to health care required to make an early diagnosis of TB. Interruption and relapse of TB treatment is more common among them. In addition, they are not being covered by social and health insurance due to their unemployment and homelessness. There are 23 centralized prisons containing more than 6,000 inmates. The TB infection rate among people incarcerated was 8 times higher than general population in 2014. Despite achievements in control of tuberculosis in prisons with the right policies, adequate funding, and active collaboration between the government and ministries still has a challenge. The rate of drug-resistant TB is increasing in prison due to delayed case detection and diagnosis of disease and suboptimal management and control. In addition, due to lack of coordination between the prison and health services, in the provincial level, the treatment and control of TB is interrupted when they release it from the prison. There are around 900 artisanal miners, mostly gold diggers, using handmade equipments. People are most likely being poor and vulnerable, have no other income source for living, not been covered by social and health insurance due to working in unofficial sector. They are at greater risk of TB and other communicable diseases. It's my honor to inform you the government of Mongolia pledges to work towards improving TB surveillance among the high-risk populations. First, in consideration of active transmission of TB in the country, which is demonstrated by the first national population-based prevalence survey, systematic active TB screening involving other social sectors regularly 1 to 2 times a year among high-risk population groups will be conducted in a coordinated manner. New technologies, for example, molecular diagnostics and screening digital radiography will be used together with proper case management. Guidelines of active TB screening are in the process of development. Second, to increase coverage of health insurance, improving civil registration services, enhance social support for homeless and other disadvantaged populations, continued involvement of civil society organizations in community-based TB services to reduce loss to follow-up. Third, Mongolia has a good progress in implementing a web-based, case-based electronic recording and reporting system. However, it needs to be improved further by enhancing capacity on good data management and analytical practices of the monitoring and evaluation teams at national and subnational levels. By carrying out routine analysis of data to inform progress towards achieving targets around key indicators and data quality. In this regard, we would like to continue collaboration with WHO in conducting periodic reviews of TB surveillance system, strengthening vital registration system, and strengthening capacity of health professionals. Thank you for your attention. Thank you.
Thank you very, very much for your clear explanation of the fact how important it is to surveillance high-risk groups and to accommodate the actions of the program. Thank you very much for that. We move to the next country, DPR Korea. DPR Korea is seriously addressing its TB problem and recently also carried out a national TB prevalence survey. My question to His Excellency, the Honorable Vice Minister of Health, Pak Myong-soo, is the following. How did the results of the National TB Prevalence Survey influence national TB policies and day-to-day programmatic operations? The floor is yours.
Thank you. 조선민주주의인민공화국에서는 2015-2016년 전국 결핵 현안을 조사 이후 결핵 통제 활동을 강화하기 위해서 다음과 같은 사업들을 진행했습니다. 첫째로 이제 전자자료 관리에 의한 전국적인 결핵 환자 등록 및 감시 체계를 더욱 강화하기로 했습니다. 2016년 전국 결핵 현안율 조사에서는 결핵 질병의 정기 등록 체계를 더욱 강화하고 그에 대한 통제 활동을 강화할 이런 필요성이 제기되었습니다. 국가 결핵 통제 계획은 정기 등록 체계를 강화하기 위해서 2018-2021년 국가 결핵 통제 전략 계획에 2018년부터 전국적인 범위에서 설립되어 있는 국내망을 통해서 전자자료 기지를 구축할 것을 이제 명기했습니다. 이를 위해서 2017년 9월부터 10월 사이에 전국 결핵 환자 등록 관리 프로그램이 개발되었고 현재 시험 중에 도입되고 있습니다. 2018년 1월부터는 정식 이제 환자 등록과 분기보 작성, 약물 주문 보고서 작성을 이제 진행할 것입니다. 둘째로서는 결핵의 예방과 진단, 치료 봉사를 개선하기 위해서 국가 결핵 통제 전략 밖에 있는 보건기관들과의 다분야적인 협력 관계를 강화하기로 했습니다. 셋째로 조선민주주의인민공화국에서는 이제 결핵 통제 지표들을 능동 환자 적발을 더욱 강화하기로 진행했습니다.
Thank you. Sorry to interrupt you.
So, after National TB Prevalence Survey 2015-2016, the PRK conducted following activities to strengthen TB control program. First is the establishment of electronic data management system on TB surveillance. National TB Prevalence Survey 2015-2016 shows the necessity to further strengthen the current paper-based TB notification system. It is defined in National Strategic Plan 2018-2021 that NTP will initiate electronic data management system since 2018 by using the internet available nationwide. Now, this software has been developed during September and October 2017 and pilot testing, and NTP will use this web-based software since January 2018 for TB notification, quarterly reporting, and drug ordering. Second is the multisectoral partnership with health facilities and health programs outside of the NTP to improve TB prevention, care, and control. National TB Prevalence Survey 2015-2016 illustrates that there are more bacteriologically confirmed pulmonary TB cases among smokers than non-smokers. This data proves that smoking is a critical factor in development of TB in DPRKI and explains the reason behind the high TB notification in males than in females. To definitely decrease the smoking rate among males, NTP developed a strategy to strengthen the partnership with other health programs, especially smoking control program, to detect more TB cases among smokers. So third is the strengthening of active case finding. National TB Prevalence Survey also showed the need to strengthen active case finding to find out more missing cases. Therefore, NTP has planned and budgeted several activities in Strategy 1.6 of NSP. By implementing this Strategy 1 or 6, NTP will optimize the active case finding algorithm, combining all the screening and diagnostic tools like symptom screening, chest X-ray, gene expert, smear, and culture examination, and apply to not only to high-risk groups, but also to those who are walking in public places, smokers, and the elderly. Strategy 1.6 also aims to strengthen the contact tracing and symptom screening, which has been implementing at the peripheral region level, and the current TB screening conducted at provincial level by using mobile chest X-ray vans.
예, 앞으로 조선민주주의인민공화국에서는 세계보건기구를 비롯한 국제기구들과 기술협력단체들과의 적극적인 협력으로 세계적인 지속개발 목표를 달성하기 위해서 성의 있는 노력을 다해갈 것입니다. 감사합니다.
In conclusion, DPRK will continue the strenuous efforts to achieve the targets set in SDGs and NTB strategy by actively collaborating with WHO, international organizations, and other technical agencies in the future. Thank you.
Thank you very much, Honorable Minister, for illustrating that a national prevalence survey can kickstart in many ways improvement in TB services. Thank you very much. It's a pleasure now to move to the Philippines. The Philippines, I think, is a recognized leader in MDR-TB service delivery models in Asia, and is currently seriously addressing the issue that in the last 2 prevalence surveys, there is a suggestion that the TB problem may not be declining. My question to His Excellency, the Honorable Undersecretary of National Economic and Development Authority, Mr. José Miguel de la Rosa, reads, kindly let us know how the Philippines will tackle the challenges of engaging the huge private sector and dramatically improve TB notifications to the Department of Health.
Thank you, Jaap. To my Russian colleagues, Davaajantsan, and to the rest, good day. Okay. The health system in the Philippines is highly decentralized. There are 5 levels of governance, starting from the national, regional, provincial or city, municipal and barangay level, which is the village level. In this system, our Department of Health serves as the governing agency with both the local government units and the private sector providing services to communities and individuals. The DOH is mandated by law to provide national policy direction, prepare national plans, technical standards, and guidelines on health, while the local government units under the Local Government Code of 1991 were granted autonomy and responsibility for their own health services, receiving guidance from the DOH Central Office and its Center for Health Development located in the regions. On the other hand, the private sector, which is larger than the public sector in terms of human, financial, and technological resources, is composed of profit and non-profit providers that cater to 30% of the population. The Philippines has one of the highest TB and multi-drug-resistant TB cases in the world. In 2017, the WHO estimated that the incidence rate of TB was 554 per 100,000, with an estimated 20,000 multi-drug-resistant cases among notified ones. The country met the Millennium Development Targets for TB in 2012, cutting TB mortality and prevalence in half compared to a 1990 baseline. Despite the efforts, the TB remains to be the 8th leading cause of the country. The program offers free TB diagnostic tests, sputum microscopy, in 2,600 rural and urban health units nationwide. However, we are to transition into using GenExpert technology, where we have 204 sites already in operation. GenExpert machines can diagnose TB and determine drug-resistant TB in 2 hours. The government then provides drugs for drug-susceptible TB for free in health centers. This free treatment is available in selected health centers and hospitals with the support of the Global Fund. Our national TB program is expanding its use of the 9-month treatment regimen for drug-resistant TB through the support of international partners like the WHO and USAID. Laboratory quality is, on the other hand, under assistance program from our partners from Japan and Korea. Private engagement is strong in the Philippines. We have a coalition of TB partners and advocates in the Philippine Coalition Against TB, or PhilCat. Our partner from KNCB provides technical assistance to support this private sector engagement. One key factor in the success of TB prevention and case efforts in the Philippines is the high-level political commitment. This is expressed through multisectoral investment in the program. This commitment is further reflected in the passage of the National TB Law, Republic Act 10767, of which the author was with us this morning, the Honorable Congresswoman Helen Tan. The law determines the multisectoral responsibilities, designates budget support, and orders the mandatory reporting of TB cases. However, the reasons for the high TB prevalence are multifactorial. Supply side and health system weaknesses, demand side factors like health-seeking behavior, and associated health problems such as smoking and diabetes mellitus. Most importantly, persistence of poverty and worsening inequities continue to fuel the spread of TB and to undermine control efforts. In the public sector, TB treatment policies are based on WHO recommendations, and for first-line treatment, adhere to the 6-month course. Thus, estimating average treatment practices in the public sector is easier than in the private sector, where decision-making is made at the level of the healthcare provider or patient. However, private sector treatment is often inappropriate. Private providers in the Philippines were reported to use inappropriate regimens 89% of the time, and it's known that patients often run out of money and so cannot complete treatment in the private sector. But according to the 2007 National TB Prevalence Survey, nearly 2 out of every 5 TB symptomatics sought treatment in the private sector, with 22% going to private physicians and the rest to private hospitals. Furthermore, the proportion of those who went to hospitals, both public and private, doubled, 42% in 2007 compared to 20% in 1997, considering that most hospitals have not adopted DOTS, the OTS. And while the private health sector is regulated by the DOH and the Philippine Health Insurance Corporation, health information generated by private providers is generally absent in the information system of the department. Engaging the private sector is crucial to improve the TB notifications to the DOH, but the question is where and how. A 2013 study revealed that 87% of doctors and private practitioners are willing to collaborate with the government for MDR TB control. The same study also shows that 100% of laboratories and 55% of hospitals are willing to do the same. However, the difference lies on the possible areas of collaboration. Hospitals identify trainings and becoming a DOTS MDR TB referring hospital as possible areas, while doctors prefer to work together on advocacy. Laboratories cited research as their preferred area of cooperation. Given the varying needs of potential private sector collaborators, the National TB Program should develop a sustainable framework for systematically engaging private providers in programmatic management of drug-resistant TB, ensuring ample site preparation and availability of technical assistance and supervision whenever necessary. On the part of government, it is imperative that we push for having information directory, better insurance package, training curricula, and involving the academe and medical associations in advocacy plan. On the part of the private sector, we hope that meaningful engagement will lead to mandatory notification, accreditation, minimum set of quality criteria, and regulation of drug sales. In closing, allow me to share with you the current programs that we have under the Philippine Development Plan for 2017 to 2022. Under the current administration, implementation of health services for human capital development is a must and a priority. And we are one with the global community, to end TB and to put a stop to it. Thank you.
Thank you very much, Honorable Secretary, for your clear exposition of the situation in the Philippines. I think it's one of the countries, and perhaps the only country in the world, that has a comprehensive TB law that must, an enormous expression of political will and commitment, and the serious efforts you are now making to engage the private sector. And I think in some of the other discussions, we will revisit that issue, but this was a very, very good illustration. Thank you very much. We now move to Kazakhstan. As we all know, Kazakhstan faces a very high MDR TB burden, but has also taken steps to improve MDR TB surveillance and MDR TB treatment delivery. And my question to His Excellency, the Honorable Minister of Healthcare, Yelzhan Birtanov, is this one. Kindly let us know about the issues Kazakhstan faces to improve the monitoring of the epidemic and the MDR epidemic, and how the country will further strengthen its electronic case-based TB surveillance system and optimize its national vital registration system with coding of cause of death. Floor is yours, sir.
Thank you, Mr. Chairman. And first of all, I would like to greet all my distinguished colleagues on this very interesting panel. Yes, Kazakhstan traditionally has been a country with a high level of multiple drug-resistant tuberculosis, and we belong to the group of 27 countries with highest distribution of this problem. So before we have started our national program against tuberculosis back in 2014, first of all, we did analysis and looked for the reasons. So there were several reasons, and the number one is the quality of infection control in medical institutions related to the taking care of tuberculosis. And mostly it was linked to the infrastructure. From one hand, the outdated infrastructure of anti-tuberculosis hospitals and clinics coming from our history. And the second, of course, the using of outdated standards for infection control and having the problem of having patients with different forms of disease in the one place. Unfortunately, in some cases, the second reason was ability to provide fast diagnostics. So in some cases, we had to keep patients without clear diagnosis up to 3 months in the hospitals together with other patients. So that also contributed to the problem. And the third reason is, I would say, historically, Kazakhstan had and still has a huge reservoir of chronic tuberculosis patients, which today is about 3.3% from all over the number of patients and more than 500 patients, and including the serious problem on penitentiary system having patients in prisons. So based on that, we developed our national plan from 2014 to 2020. So then there are several major directions of improvement and fighting against the epidemic. First, it's of course redesigning of care. Redesigning of care aimed on the putting the patient in the central position. It's not only for tuberculosis, it's overall for all healthcare system, but in tuberculosis services, we are trying to integrate outpatient care for TB patients with primary care, so being able to more efficiently monitor the disease and manage the disease on a safe status. And also strengthening the hospital sector, integrating smaller units into the larger units, being able to free additional financial resources to improve the infrastructure. The second direction is, of course, the standards of care. So, and first is ability to provide good and high-quality diagnostics. So we invested a lot together with our international partners to build a national network of more than 20 laboratories with a national reference laboratory on the central level, on the level of National Scientific Center of Tuberculosis. And also switching to the modern treatment protocols based on the latest and evidence-based data. And again, I would like to thank our partners from WHO, from Global Fund, Partners in Health, in introducing such technologies and involving Kazakhstan in these programs. The third area is, of course, how we finance the service. And there's a lot of transformation going on, but basically from this year and especially from the next year, we are centralizing the whole budget for treating patients with tuberculosis and avoiding the previous problem when we had a different level of funding in different states of the country, ending up with the different quality of care in different regions. So together with that, we will be moving to the more effective ways to financial support this sector. The next direction, I think it's very critical, is about developing human resources and providing continuous professional education to physicians, nurses, and social workers working in all levels of care. And the last but not least is, of course, the key issue of monitoring and collecting data in the system. Starting from 2001, we launched our national database on patients with tuberculosis, and currently we have information about all 17,500 patients that we have in our country. We have this data in this national register, and the current issue is how to make this data more valuable, and the key issue is how to link this database with other information systems that we use. We use around more than 20 different information systems, starting with the basically statistical system for primary care. So now we have integrated this database with the register of all primary care institutions. But the next step is, of course, go forward with digitalization of the whole medical services and special primary care. So we put a plan within the next 2 years to provide all, I would say, primary care specialist electronic workplace where they can use only electronic patient records. And this data will be collected on the centralized platform and will be linked with all registers. So today, in the past, we had the problem that, for example, we have a list of patients with tuberculosis, but it doesn't match with the list of patients with HIV or mental diseases. So creating such a platform that is aimed next year will help us to integrate all databases and provide physicians a quick access and save a lot of time, actually, to follow up and to manage their patients on the pre-hospital level. So integration of all information systems will help us, we believe, to improve the quality of outpatient services for this group of patients. Also, of course, it will help us to generate quality reports, to take managerial actions, and to report to WHO. A serious problem is integrating with penitentiary system database. Of course, it's traditionally very close area, but today we have very good intersectoral cooperation with Ministry of Interior. The last thing that I want to mention, I think, which is very critical and important to involve, general population in health information systems. So traditionally, we used health information systems to communicate within the system between healthcare professionals. But now we see how people are more and more involved in taking care of their health and taking care of their chronic diseases. So our digital program for healthcare, based on the massive integration and involvement of people, so we are creating electronic patient health records for each citizen of Kazakhstan starting from next year. So every person will be able to manage his data, will be able to get clear and quick information about his health data. But more important, he will be able to use modern information communication technologies to work together with the health professionals. And I'm talking about digitalizing disease management programs. So today we started with digital mobile applications for diabetic patients, for patients from cancer disease, etc., with major non-communicable diseases, but also I think we should involve patients in managing and his data with major disease, including tuberculosis. So we believe that's a very important direction. We will support that. And coming to the end, I want to say that we believe that overall primary care and specialized care, including the care for tuberculosis patients, will be transforming under the pressure of modern technology. So that's why it's my pleasure one more time to invite distinguished colleagues to discuss the historical Almaty Declaration. And I would, my big honor to invite you all next year, October 25th, to Almaty to celebrate 40th anniversary of Almaty Declaration, where we hopefully can review and add some modern approaches and visions to this historical document. Thank you very much.
Thank you very much, Honorable Minister. May I take the privilege of the chair to ask you an additional question? That is, I know your country has a well-developed vital registration system. Could you reflect or share something on that system?
You mean what registrations?
National Vital Registration System is coding of causes of death.
Yeah, we started our National Health Information System quite a while ago. In 2004, we developed the main concept and started to implement, and we've went through several stages actually, because technology is, transforming, changing very fast. So of course, and in this way, we are always trying to improve, So because it will take some time to design and implement any kind of registration information system, and as soon as you have implemented, you trained your professionals, you start using, it's already outdated. So that's why we're currently moving all our systems to the cloud format, to the centralized platform, and trying to integrate all existing systems so it will be more comfortable for healthcare providers and any other kinds of professionals involved in filling those registers to work more quickly and to save time and to make it more comfortable. So of course it will require overall strong efforts to train healthcare professionals to be able to use these digital technologies. So and there is a special programs in those directions are very important as well.
Thank you very much, and thank you very much for sharing with us the important steps in modernizing TB control that your country has been taking in addressing effectively the MDR problem and specifically the MDR TB surveillance issues. Thank you very much. We now move, and it's a pleasure for me, to the Netherlands. The Netherlands is a country that has been able to bring down tuberculosis and is now actually in the elimination phase of the disease. Also, KNCV is recognized globally as a center of expertise. My question to the distinguished Executive Director of KNCV is the following. Could you share with us the Dutch experience in having the private sector successfully engaged to the extent that 80% of all notifications actually come from the private sector? Kitty.
Thank you, Jaap. It's an honor to be a part of this distinguished panel. 80%. 80% is an important figure in the Netherlands because also 80% of our patients are foreign-born. So we are in a very special situation. Already for 5 decades, the private sector has been included in our case notification system. But if you look at the first, the red bullet, measure with pleasure. Most hospital physicians do not like to collect data. And working in so many other countries, we all know that it's impossible to ask the private sector to collect 130 variables on every single patient. So already for a very long time in the Netherlands, we have divided the care around one patient between the private sector and the public sector. So we use the private sector to do what they're good at. And the private sector means hospital sector, lung physicians working in either public or private hospitals. They see the patient, but you cannot expect them to organize routine contact investigations, to go to the houses of the patients and inform them. And as I said, 80% are foreign-born, many vulnerable patients also in our country that require special care. So we created a win-win situation where the public sector, the NTP, joins forces with the private sector around one patient when it comes to case management. So the private physician notifies the case, and the nurses and doctors in the public sector make sure that he or she is supported during the whole course of treatment. Now, you could ask what happens to the other 20%? If 80% is being treated in the hospital sector, what about the other 20%? As I said, you know, in many countries, TB concentrates in vulnerable groups, and it's the same in the Netherlands. We have illegal immigrants, and we allow them to stay in our country for the full duration of treatment, but they cannot easily access and get around in the hospital. Drug addicts, homeless people, very recent immigrants, all of them are taken care of in the public sector that have tailored approaches to take care of this group of patients that require extra care. Working in other countries, I think it's the same everywhere. We can expect the private sector to do A, B, and C. Quality, accreditation, linkage to insurance schemes, extremely important. But still, we have to maintain a public capacity to arrange for the proper care for the patient, his family, household contacts, etc. And a digital health is becoming very important to provide the private physicians with apps that they can easily refer patients. And I'm going to close in a very strange way. Speaking of a digital health, I just realized sitting here that I lost my mobile phone. And it must be somewhere here. It's my lifeline also with my boarding pass. I know so if I just want to take the opportunity, look around, it's white and it's somewhere here. Thank you very much.
I will call you and we will find out.
Oh, that will be good, yeah. It might be silent. Thank you.
Thank you very much, Kitty, for showing that the work of engagement with the private sector can be done, and that actually it definitely will contribute to substantially reducing the problem. Last but definitely not least, we move to Latin America, to Bolivia. Bolivia is seriously addressing its imposing national TB problem, but faces critical challenges in involving the private sector providers. And my question to His Excellency, the Honorable Vice Minister of Health, Dr. Álvaro Peláez, I hope I pronounced correctly, is how do you plan to drastically improve engagement of this private sector and other private providers to ensure notification of TB cases from this sector to the National TB Program and the Ministry of Health? The floor is yours.
Gracias por darme el uso de la palabra. Quiero y me permito hacer un saludo, gracias al moderador. Saludo a todos los hermanos, hermanas, representantes de todos los pueblos del mundo que están presentes aquí. y le damos tiempo a los traductores para que se alisten. Bien, si ya están los traductores.
Just continue and we will wait for the translation, please.
Ok. Bueno. Bien, el sistema de salud boliviano ha ido evolucionando y especialmente los últimos 10 a 11 años estamos con la traducción. ¿Is the traduction ready?
Sorry, I don't know what's happening.
All right. Bueno, los últimos 10 años el sistema de salud boliviano ha ido evolucionando y flexibilizándose con políticas cada vez más descentralizadas y participativas, especialmente los últimos 11 años. Está proyectado la conformación e implementación de un sistema único de salud en Bolivia. Actualmente, el sistema de salud boliviano está fragmentado, lo cual hace y dificulta mucho el monitoreo y el seguimiento del programa de tuberculosis. Tenemos cerca de 1/3 de la población que está en los seguros sociales de corto plazo y casi un 70% que están en el sistema público de salud. Esta situación ha impulsado a que el gobierno desarrolle una política que la denominamos SAPSI, que es la salud familiar, comunitaria, intercultural. Este concepto me gustaría que lo recalquemos, que es que tiene un enfoque intercultural, transcultural, no étnico, comunitario y familiar, además de reconocer e integrar a la medicina tradicional, con el objeto final de eliminar la exclusión social a la salud que involucra a los actores sociales en los procesos de decisión y la gestión de salud. Es decir, que la población organizada, el pueblo organizado desde abajo, a través de sus organizaciones sociales y naturales, participa en la elaboración de los planes operativos anuales, es decir, participa en la elaboración de los presupuestos locales de salud a través de los municipios inicialmente. Esto ha permitido reunir las necesidades sentidas con las necesidades reales y nos ha permitido acercarnos más aún a la población y atender sus necesidades y saber cómo abordarlas a ellas. Es importante que dentro de la política SAPSI, y secundando las palabras de aquí el hermano ministro con respecto a Alma Ata, la atención primaria de salud la consideramos como elemento primordial para poder recolectar la información. No solamente esperar que los centros y establecimientos de salud notifiquen los casos que se van detectando, sino hemos dirigido a través de una política, una estrategia que se llama Mi Salud, más de 3.000 médicos que se han desplazado a 330 de los 339 municipios que hay en el país. Estos médicos van emulando la estrategia de prevención y promoción de salud cubano, casa por casa, vivienda por vivienda, que van anulando esta brecha de accesibilidad a los servicios de salud cuando es el médico con su equipo, la enfermera y el odontólogo, van casa por casa recolectando la información, lo cual nos ayuda para la vigilancia epidemiológica. Hemos tenido éxitos rotundos con esta estrategia, donde las áreas de influencia de este programa en los 330 municipios, en las zonas más alejadas, tenemos, por ejemplo, mortalidad materna 0. Hemos logrado también disminuir a la mitad la desnutrición infantil. Y también estamos empezando a aplicar la vigilancia epidemiológica, entre estas la lucha contra la tuberculosis. El sistema y el modelo boliviano de salud está estructurado por 3 niveles de atención y organizado en redes de salud de acuerdo a los tipos de establecimientos de salud. En este sistema nosotros tenemos cerca de 3.663 servicios, de los cuales son 1.927 centros de salud, 1.452 puestos de salud, 218 hospitales básicos, 39 hospitales generales y 27 institutos especializados. Podrán ser quizás, en comparación a otros países, números bajos. Y uno de los principales problemas que tenemos en Bolivia es la densidad poblacional. Es una población, si bien que está concentrada en las ciudades, casi un 60% de la población, 70%, pero en el campo está disperso. Y esa accesibilidad es la que, de la población, es la que pretendemos cerrar la brecha a través de estas políticas de la salud comunitaria e intercultural. La atención de tuberculosis en el país la realizamos a nivel nacional, igual a través de Fondo Mundial y fondos estatales. El acceso a los medicamentos, el tratamiento, el diagnóstico es de forma gratuita. Pero ¿qué hacemos con los privados? Con la Seguridad Social hemos logrado hacer alianzas estratégicas, igual con el sector privado, con las ONGs, organizaciones no gubernamentales. Y nos está permitiendo recoger de ese 30% que corresponde a la Seguridad Social casi un 90% de la información. Aún nos falta mucho más. Tenemos una brecha actualmente, nosotros tenemos una tasa de incidencia de casos notificados de cerca de 69 por 100.000, pero tenemos una estimación de 120 por 100.000. Es la tercera más alta de la región de las Américas. Esta brecha aún tenemos que cerrarla. Hay un grueso de casos que no están siendo notificados. Y es donde tenemos que efectuar a través de lo que nosotros estamos trabajando en el Sistema Único de Salud, que también va a contemplar el manejo del expediente clínico único. Esto ya fue anunciado a nivel gubernamental, lanzamos a mediados del 2018. En esta alianza estratégica a nivel nacional ha permitido hasta el momento aumentar la detección de casos, disminuir la demora de los diagnósticos, garantizando el acceso a tratamiento y el manejo de la tuberculosis bajo el marco normativo vigente, además de permitir llegar a la población vulnerable que no accede a los establecimientos públicos y fortalecer a los recursos humanos que forman parte de estos establecimientos de salud. Gracias.
Thank you very much, Honorable Minister, of sharing your country's perspective with us and the seriousness in which you are engaging the private sector in TB control activities. I think we have done very well time-wise. Maybe there is a few minutes for discussing with you some aspects of strengthening notification, strengthening vital registration. Perhaps there are some points that the panel would like to make based on the presentations from the various countries. I look around if you have missed on any important point or if you would like to add or subtract on some of the approaches developed during this panel discussion. Dr. Birtanov,
can I ask
please.
a question to my colleague? I want to ask Htwe regarding the problem that you mentioned about a huge pressure of migrants to this overall problem in your country. Kazakhstan is also facing the problem of migrants moving from through Kazakhstan, mostly coming to Kazakhstan from sovereign countries and moving through Kazakhstan to Russia. So in knowing the origin of those patients, is it possible to build some kind of the interaction and especially in data exchange with healthcare systems of countries where they're coming from? Do you have any advice on that? Thank you.
So that's in fact part of the role of our NTP, to link up when people with the country of origin, especially if patients want to come back, because we want to make sure that appropriate treatment awaits where they're going. But I think there's a lot of experience now with cross-border information systems in Asia, in Europe, and I think that we might want to make it more formalized, because now it's really the Dutch National TB program, you know, taking the initiative, but then whom to call in your country. So I think this whole cross-border migration is something that needs to be developed further, and we have excellent examples, for instance, at the border of Cambodia, Thailand, etc. But I agree, for us, I mean, because the immigrants can stay and be treated, there's less a necessity. It's when people get TB in airplanes most of that then we reach out. But because they can be treated in our country, it's complete treatment. It's less of an issue. But Western European countries deal very differently with immigrants. So it's maybe something to discuss in the European context of the Wolfheze conferences or next year a union meeting.
Thank you very much. Any other point that you would like to raise? We are coming close to lunch, but of course important issues have to be addressed. Perhaps in the audience? I hear yes, but I don't know where it comes from. Sir, you get the microphone. I allow for one question and then we have to wind up.
Thank you very much. Really, it is very important. Thank you for all the high excellencies which they have propounded. I am Dr. Mohammed Jabal, Ministry of Health, Iraq. But we haven't heard two main approaches, which is very important at the time being. As regards the CCM, CCM is very important, really, country coordinating mechanisms. They are very, very important, and they are headed by the High Excellencies, the Minister of the Health in the countries, and they are very important in the monitoring and evaluations. And this has been really ascertained within all the Geneva meetings, within the Global Fund, that the CCM is one of the important approach. The second thing, we haven't heard about the family medicine and family health, evidence-based practices, which are now being done all over the countries. These are, we do think, they are the main approaches that we can reach for all the cases of the TBs. And why? Because this is really, we have a firing system and we have really approachable approach for that, and it is covered within the primary healthcare approaches. Thank you very much.
Thank you very much. It's at least a pleasure that we have had a discussion with the panel and a discussion with the audience. Time does not allow further, but perhaps